In 2024, initial medical claim denial rates reached 11.8% across the healthcare industry, and that number is steadily climbing. This chart breaks down those rejections. The largest slice, 30 to 35% of denied claims, is coordination of benefits errors. Across the U.S. healthcare system, this drains over $800 million annually, with $480 million directly recoverable by providers, optimizing this workflow. The penalty for these errors is steep at the practice level. The administrative cost to rework a single denied claim now sits at $57.23. These costs compound because coordination of benefits leakage rarely surfaces in real time. It hides for weeks, finally appearing as past due metrics glowing red on an aging accounts receivable report. Coordination of benefits resolution cannot be treated as a background administrative task. It is the single largest preventable driver of denied revenue in medical billing today. The breakdown starts at the front desk. Current industry data shows that 65% of consumers struggle to understand what their health insurance actually covers. Patients routinely fail to record secondary coverages or overlapping policies, creating an immediate data gap before they even see a physician. Coverage also changes mid-year. Job transitions, dependent aging, or a patient turning 65 often go unrecorded in the practice's system until a submitted claim bounces back. A biller must take the primary remittance, calculate the balance, and precisely sequence a secondary claim. If the secondary payer doesn't receive that data in their exact electronic format, the claim hits a barrier and enters a continuous rework cycle. Despite this friction, nearly 2/3 of these delayed or denied claims can be recovered if the right structural systems are in place. Without redundant verification, front-end data gaps inevitably become back-end write-offs. Practice leaders assign complex COB queues to generalist billing staff, treating it as standard data entry rather than a mechanical labyrinth of legal hierarchies. A biller must first memorize a foundational layer of federal standards, starting with the baseline birthday rule to determine primary coverage for dependents. This decision tree maps the compounding difficulty. Adding Medicare secondary payer regulations splits the workflow. Employer-sponsored plans introduce ERISA coordination standards, appending a highly complex interconnected branch. Stacked on top of those baselines are dozens of payer-specific variations, shattering the standard workflow into microscopic contradictory rules. A biller who mastered this process on one specific EMR system or regional payer mix is rarely equipped to handle coordination of benefits for a different patient population. Accurate resolution requires specialized, credentialed knowledge of legal and payer hierarchies. An overworked generalist simply cannot manage this level of complexity. This required specialization collides directly with a labor market crisis. 53% of medical group leaders rank finding qualified candidates as their absolute highest operational hurdle. Medical practice operating costs recently surged an average of 11.1% year over year. Breaking down that upward trend reveals that staffing costs, salaries, benefits, and competitive pay adjustments consume the vast majority of this operational inflation. The daily reality for the modern in-house biller is a constant juggle, forced to manage prior authorizations, verify patient eligibility, and answer patient phone calls while trying to clear a dense COB queue. When that single overwhelmed biller leaves, the practice suffers a hidden, devastating cost. Critical, localized institutional knowledge evaporates. It takes months to rebuild an understanding of a specific payer mix. During that transition window, the queue backs up and denials spike. Rising labor costs and workflow complexity make the traditional in-house hiring model financially and operationally unsustainable. The alternative is a structural shift, transferring coordination of benefits resolution to a dedicated credentialed team that exclusively works this specific queue every single day. This external team does not replace existing infrastructure. They integrate directly, working securely inside the practice's current EMR system. Deployment is highly compressed. Access is established within 48 hours, going live in just 14 days. An in-house biller costs roughly $75,000 per year. By contrast, the outsourced model operates at $399 per week, locking in at approximately $20,748 annually. This creates direct savings of up to $54,000 per seat, entirely removing unpredictable turnover costs. Outsourcing this specific queue is a structural financial maneuver that permanently insulates a practice from local labor market volatility. Beyond deploying human experts, this specific model leverages powerful AI-augmented workflows to actively intercept claim delays before they ever occur. Smart routing technology automatically categorizes and assigns incoming tasks based on individual claim complexity, payer type, and urgency. Automated audits continuously scan the workflow, identifying potential payer order errors or missing attachments prior to final submission. Combining credentialed human expertise with these AI audits yields a decisive result. Operational error rates consistently stay below 1% across thousands of practices. Practice leaders maintain total visibility without the administrative burden. Performance is tracked week to week through a specialized dashboard displaying throughput, accuracy, and return on investment. The business arrangement maximizes operational flexibility, moving to a month-to-month structure with no long-term contracts required after the initial pilot. Healthcare leaders must stop letting recoverable revenue age into write-offs. By initiating a 14-day risk-free pilot, practices can permanently clear their backlog and mathematically restructure their unit economics.